I'll introduce everybody. Welcome everybody, good afternoon. Welcome to the AHA Health Tech Researchers session here in the Health Innovation Pavilion. It's great to be with you all. We're going to have a panel discussion and then an innovation showcase. So after the panel discussion is completed, please do stick with us for the innovation showcase. It's going to be a great way to cap off the day. So I'm going to start by just introducing this distinguished panel we have. This is folks that are going to shape the future of healthcare through health tech research. So first of all, we have Dr. Aaron Mikos, one of my close colleagues, a cardiologist at Johns Hopkins who has many hats, including directing the Women's Health Research Group, as well as leading our AHA SFRN on diversity in clinical trials. So Aaron's going to be moderating our panel. We have Dr. Jesse Golbis, who's a cardiologist at University of Michigan, and is also a member of the Health Tech Advisory Group for AHA. Jesse's been a fantastic collaborator in the AHA SFRN. Great to have you here, Jesse. Dr. AJ Blood, where's AJ? There you are over there, who's a cardiologist in Boston at Mass General Brigham, where he directs medical operations and innovation. AJ's done some really innovative research on hypertension and lipid drug titration using technology. Excited to hear your thoughts, AJ. And then we have Dr. Asif Ali, a cardiologist at the University of Texas Health Science Center in Houston, who's also a member of the Health Tech Advisory Group to AHA. So this is our distinguished panel that you're going to be hearing from. And then we also have our innovation showcase. We have Dr. Nick Hendren, who's a cardiologist at the UT Southwestern, where he's doing innovative research in heart failure. Great to have you here, Nick. Dr. Rhoda Au, who's a professor of anatomy and neurobiology at Boston University, has been a great collaborator in the AHA Health Tech SFRN. We have Dr. Mir Krieger, who's professor emeritus at Yale University. Great to have you here. We have Dr. Nino Isakadze, who's a cardiology electrophysiology fellow at Johns Hopkins, one of our star, was our first AHA Health Tech fellow, is doing really innovative work that you're going to hear about, building a digital atrial fibrillation program. So really great to have you here. We're all good. Hopefully the tech still works. And then we have Doug Romer, Chief Medical Officer at Medisync. Welcome, Doug. It's great to have you here. And then finally, we have Joseph O'Rourke, the Head of Commercial Development and Clinical Trials at Walgreens. So thank you. Please join us. So that's our distinguished group. These are folks that are going to shape the future of healthcare. So I'll ask you all to please, a round of applause for our distinguished panelists and Innovation Showcase members. Please make yourself comfortable. I'm going to offer some opening remarks and then we'll get started with the panel. Why don't I make sure this, after this drop, that the slide thing is still working? Yeah, it's still working. Good. Okay, so there you have everybody listed. Okay, so I have a few minutes just to offer some opening remarks. I first wanted to, again, big kudos to Pat Dunn, the AHA team, for putting together a fantastic program here in the Innovation Pavilion. Also want to thank and acknowledge AHA for being a leader in funding health technology and innovation research. We're very grateful that in 2020, the AHA invested $14 million in the AHA SFRN on health tech and innovation. And so we at Hopkins and Michigan and BU and Stanford and Cincinnati were very fortunate to be part of that network. And AHA's really brought us together and really asked us to focus on our collaborative and innovative spirits to shape the future of healthcare. We really, as I mentioned in some of my remarks this morning, we need a shift in innovation from not just what new biopharmaceuticals can we bring to bear for our patients, but how can we innovate in the way that we deliver care to our patients, the how. How do we design systems, programs that can scale and build a better future for our patients? As we shift our mindset to greater focus on the delivery of care, I would charge us also to do this with an equity-first lens. That means that we build from the ground up with diverse patients and other parties of interest using methods such as human-centered design to work with the problem, deeply understand it, work backwards to the solution. And then as we use technologies, that we don't create unnecessary disparities, but we actually use technology to form bridges that ultimately lead our patients to better health outcomes. And as we do the trials that form the basis of the future of healthcare, that we do that with the mindset of bringing in more diverse patients that have typically been included in clinical trials in the world of cardiology. So the work that Dr. Aaron Mikos and others are doing in AHA's Diversity in Clinical Trials Network, I think, is highly relevant to the health tech research because we have an opportunity to really bring more diverse patients into these trials as we build that research foundation. I'd like to share a patient's story, what it really looks like to engage patients with digital health technology. So one of our patients whose case reports we publish and we've talked about in some of these sessions is a patient named Tammy, who had a clamshell phone to begin with, came from an under-resourced part of Baltimore. She became enrolled into one of our clinical trials using a smartphone technology, very quickly was able to use it because of the intuitive interface. She binge-watched the educational videos, which is something that we've heard from our other patients, felt more confident asking questions of the team on rounds the next day, started to track her steps on her Apple Watch as she went around the nursing station, and she walked out of the hospital much more confident that she knew what she needed to do as part of her care. She went home and started cooking salmon and green beans for dinner, totally overhauled her risk factor profile, got promoted at her job at Walmart, and really has gone on to lead a much, much better life. And digital health technology can connect with patients like Tammy and many others out there. And so there's this real opportunity to scale this beyond just the small numbers of patients represented in pilots or small trials, but really to much bigger populations. On the clinician side of things, of course, we're dealing with burnout and challenges with the EHR, and we need to think about how is technology our friend as clinicians and help bring back the joy in medicine, help us integrate technology with team-based care to provide more efficient care. So I challenge us as we engage in the panel discussion to think about how we bring this all together, how we get out of our silos and drive more collaboration and synergy to build this future of healthcare. And so with that, I will turn it over to Dr. Aaron Mikos and our panelists to start the panel discussion. And I've been asked to join the panel, so I will stay on stage for that, and looking forward to this discussion. So thank you to all of you. Please come up. As folks come up, I'll just thank everyone in the room who's here. This is really a collective effort, I think, to come together and shape the future of healthcare.
Yeah, you can sit down there.
You'll see.
Yes. All right, I want to welcome our esteemed panelists to the stage. And as a reminder, we have Dr. Jesse Golbus from University of Michigan, Dr. A.J. Blood from Mass General Brigham, Dr. Asif Halai from the University of Texas Health Science Center, and my colleague, Dr. Seth Martin from Johns Hopkins. So this session is going to be about health tech researchers or health tech for research. And we have 4 esteemed faculty who are all doing innovative research that incorporates health technology. And so to get to know our panelists a little better, I'm going to have everybody go down the line and just briefly summarize your research and how you're incorporating health tech in your research. If it's possible to summarize it briefly. We can start with Dr. Ali.
Sure. So Asif Ali from University of Texas, and been very focused in the last 5 years on cuffless digital blood pressure monitoring that can be given to consumers pre-calibrated. So that requires that we actually look at age, gender, and very important when we look at inclusion criteria to look at Fitzpatrick scales. So there's 6 different type of skin types that have been determined by a scoring system called Fitzpatrick. And we have to look at the wearable devices and the actual monitors that, light sensors that they're using may not penetrate darker skinned individuals. So there's inherent biases if you don't include a diverse population. That's part of what we're talking about today. But also making sure that you determine the Fitzpatrick scores and making sure that you're including that wide variety of different skin types so that the digital tech is for all and not just for some.
Great. AJ Blood, Mass General Brigham. We do a lot of cardiometabolic research and scalable outpatient chronic disease management across hypertension, hyperlipidemia, heart failure, obesity. We build a team-based structure and do entirely remote care for chronic disease management, from device setup and integration into the electronic health record to pharmacist-driven medication titration under a collaborative drug therapy management program similar to a Coumadin clinic. We've built out algorithms across those disease states to allow for a much more population-based effort that can help control chronic disease, and published a 10,000 patient trial last year and have built out more disease areas in the subsequent years and are continuing to grow.
Hi, I'm Jessie Golbus. So I'm really interested in working with our team to think about how we can use mobile technology for behavioral management in patients with cardiovascular disease. So we're really interested in just-in-time adaptive interventions, which is leveraging contextual data from wearable devices to deliver in-the-moment support to patients when they most need it. So a lot of our work is focused on physical activity, but also dietary interventions.
And so again, I'm Seth Martin. I am a cardiologist at Hopkins. I direct our MTech Center funded by the AHA. I have the pleasure of working with Dr. Nino Isakadze, who's taken a picture right here in the front row, Dr. Aaron Spalding, Chang Kim, and others in the audience who've been really working on our, to take that story that I shared with you and scale that in other ways to activate patients and really help implement all that we know from the evidence and the guidelines. Within the AHA-SFRN, we've been focused on cardiac rehab, and so we've taken a human-centered design approach to build out our smartphone technology paired with Apple Watch and blood pressure monitor, clinical dashboard, as well as clinical coaching from exercise physiologists to build a hybrid cardiac rehab program. Dr. Isakadze is also scaling things on the AFib side of things. So we're really focused on scaling this patient activation, better clinician-patient partnership to implement the guidelines. It's been great to work with Jesse and others. We also have a PCORI-funded trial across multiple institutions testing this hybrid approach to cardiac rehab.
Great. So I'll start us off with a kind of a difficult question. So as you knew that I'm a part of another AHA-SFRN, the Diversity in Clinical Trials. And to make research applicable to the patients we care for every day, it's really important that our study participants are diverse and representation of our patient population. So when we think about health tech, all these gadgets and things are really cool, but what about the digital divide? And so I wanted to ask our panelists about whether incorporating health technology will make research either more accessible to these underrepresented groups or perhaps less accessible if they don't have the right tech for this, such as reaching minority, racial, ethnic groups and those from lower socioeconomic status. So I'll start with picking on Dr. Blood because he did a work in a very large healthcare system in which some of the patient populations were from these underserved backgrounds. So what do you think about the digital divide in health tech for these populations?
Really important issue, and I think to a point that was made earlier, going back to kind of patient-centered design and starting from the ground up with something that is accessible to all and doesn't require either a bunch of knowledge, money, technology literacy, or these devices being already owned is a big part of what we thought about when we built this from the ground up. So we actually don't require the patients to own or have any device. There's no Wi-Fi or Bluetooth necessary to enroll in any of our programs or trials. We use cellular-based blood pressure cuffs, both for ease of setup, pre-registration, and syncing into the electronic health record. We also, that was a big learning for us when we started. We were using Bluetooth and Wi-Fi enabled devices, which was a major barrier for some patients. The other component is, we do use email, text message, secure patient gateway at the patient's preference. Primarily, most of our interventions are done over the good old-fashioned telephone. The vast majority of our patients within Mass General Brigham have access to a phone. Sometimes it is a good old-fashioned clamshell, but at least they're able to pick up the phone, have a conversation. We also, for our programs, have built out and hired members from the community who speak the language of the patient population that we're dealing with so that we're able to communicate in their native tongue. We're able to make our recommendations for medical, diet, lifestyle interventions that are above and beyond just the medication management that we're doing in a way that's culturally sensitive. So absolutely, it's important to build those things in from the ground up. However, if done correctly, it doesn't create a barrier. It actually can enhance their interaction, their ability to access the healthcare environment. And that's the way that we try to frame every piece of tech that we use as a tool to pair with patients.
Does any of the other panelists want to add to that? It was great comments.
I think it's so important we're having this discussion, first of all. In our center in Houston, I think it's very important to have multi-center trials and making sure that it's not just representative of one population. In our trial, it's an N of 500 that we're looking at various Fitzpatrick scales, as I talked about, in wearable devices. And I think we have to set kind of a standard for inclusion. And I hope after this panel, we can come up with hopefully a bar where all devices say, we need to have X percentage of inclusion, X percent of exclusion, but that inclusion really needs to be a population that's representative of the U.S.
Yeah, I mean, I like a lot of what's been said already. We've taken a smartphone-based approach and we've loaned smartphones to people, but that resource is not necessarily available outside of a study, a clinical trial where you have those resources. And I really like what's been done in Boston with, a lower kind of tech approach to reach people. And I think ultimately probably programs in real world practice, you'll have to have those different options depending on the resources that you have, to really meet people where they are. And the other aspect of this, it is that if we take that approach, we really there can be strategies for recruitment to have more diverse participants in trials, as you all are figuring out within the Diversity in Clinical Trials Network. But if you have artificial exclusions that lead people not to be able to participate because they don't already own some device or so forth, that could lead to lack of diversity. And you all, had actually, I would say, pretty impressive demographics in the implementation studies you've done. I think partly because of the choices you made to lead it to to really include people rather than exclude people.
Right.
Thank you.
Well, another topic that I'm very passionate about is advancing women's health. And we know, unfortunately, historically, female participants have been substantially under-enrolled in cardiovascular clinical trials, about 25 to 30%. And so I was wondering about whether using health tech can actually improve enrollment of women. Particularly, I know some of our panelists have been involved in cardiac rehab. We know that female patients are less likely to be referred to cardiac rehab and attend to cardiac rehab because they may have more challenges being caregivers in their own environment. So I'll start with Dr. Golbus. In terms of using health tech, whether this helps improve female representation, and have you noticed the women enrolling in cardiac rehab when digital tech is available?
Yeah, this is a great question. Thanks so much, Erin. Well, I think we've thought about that within our group in a couple of regards. I think specifically to your question of cardiac rehabilitation, I think that there's a lot of potential there, and it's something that we're now studying as part of a clinical trial that Seth had talked about. So this is a PCORI-funded study. Patients are being randomized to in-person cardiac rehab or to telehealth cardiac rehab, and so we're really focused on identifying who telehealth cardiac rehab works for, and does it allow us to increase enrollment of some of these populations that have historically been underrepresented. So I think that there's a lot of evidence to think that a telehealth approach will help us improve representation in clinical trials, but that's something that we're formally evaluating. The other thing that our group has done, kind of speaking to your earlier question as well, is we've conducted almost all of our clinical trials completely remotely. And so we have consented people through using a phone, mailed them a smartwatch, and then conducted these remote enrollment appointments. And we've been able to, therefore, not require people to come to the University of Michigan, so reaching people that might have geographic restrictions, and then also to offer consent and enrollment appointments at non-traditional times, so evening study visits. So hopefully that's something that's improving representation in our trials.
Great. Yeah, so another demographic that's under-enrolled in cardiovascular clinical trials is older adults. And I know, my mom, I'm always helping her set up things on her Android phone, and sometimes she has a little difficulty with tech. So what about incorporating, this population in trials? Is health tech for research a barrier for older adults, or could it be potentially helpful because of the remote virtual aspects of it? Maybe Dr. Ali, do you want to start off with that?
Yeah, we have this conversation all the time, and nowadays, grandparents are sending text messages and photos all the time. And if you can do that in general, I think that's where advances in human computing, just making it very simple. I'm talking about devices that you just put on and it automatically captures the data. And the more we can have individuals not have to consciously collect data, if we can do it passively through day-to-day activities, I think it's going to accelerate not only the adherence and utilization, but just make it that much easier. I think there have been plenty of studies that if you have to do 3 different points to get to an endpoint, it's not, the attrition rate's terrible. It needs to be just a one point of care and it's done. And I don't see that being as big of a barrier as long as there's some networks. In fact, in the studies that we're doing right now on blood pressure detection on wearables, we're actually studying the population from 60 to 90-year-olds. So we're literally, that is our N of 500. It's diverse populations, 60 to 90-year-old. And believe it or not, they can do it. You just have to explain it, give them something to be able to call a service rep, and they're able to do it.
That's fantastic. Does anybody else have any comment before I move on to the next question? Do you have about?
Yeah, I mean, in our prior studies, we've had quite a bit of older adults. Naturally, if you're enrolling people with heart attacks or into a cardiac rehab population, you're getting older adults. And we've found that there's tremendous interest in using technology. Sometimes they're the best super users of technology. They have the most time. If they're retired, they have more time than someone to interact and be involved. And yes, that it does minimize, travel burdens and so forth. Keep a lookout for some data out of the ERIC study. Dr. Aaron Spalding is really leading a part of the ERIC study. This is a population that's above the age of 80, an NIH cohort that's been followed for a number of years. There's going to be about 800 to 900 of them that are going to get Fitbits on their wrists for years in that study, and we're going to learn a lot about the connection of older adults with technology, the onboarding experience, the ongoing interaction with technology, and what can be learned in terms of risk prediction. So I just want to give a shout out to that's launching right now.
Oh, fantastic. So I wanted to move to another hot topic, which is artificial intelligence, and I'll start off with Dr. Blood about wondering if there's ways that, or either you're currently using or planning to use the use of large language models in your research.
Yeah, great question. I think it's a very hot topic, big area, a lot of excitement around it. I think how do you actually implement it safely, gradually into clinical care, into research is important, and doing it in a regimented way. I think one of the challenges we see with these large language models is hallucinations, which are and even another major challenge is that you ask the same question at different time points, even with the exact same model, and you can get different output. So how do you do really high quality, rigorous research on something that is in a lot of ways still a black box and exactly how it gets to the output that it gets? So I think ways that we're starting to incorporate it into our research is starting first with non-patient facing activities. So actually in a lot of our clinical trial screening, we're starting to use HIPAA-compliant, lockdown, secure models of EHR screening to have it take a list of patients who we think are eligible and compare how a large language model does screening for trial eligibility as compared to our research assistants, who are normally the people who are doing those activities. And so that's our kind of first dipping our toes in the water, seeing if we can grab some operational efficiency out of some of these tools and models. As we start to crawl before we walk, a lot of the frequently asked questions and in our platforms, a lot of the patient interactions that we have are oftentimes not about what they should be doing with their medicine. It's about how a blood pressure cuff works or what the next step is in the process. So actually doing supervised, human in the loop, automated text responses through emails and secure patient gateway. So really trying to gradually, in a monitored, detailed, safe setting, starting to incorporate those tools, I think can lead to operational efficiencies. But we want to be really careful and make sure that everything we're doing is regimented, studied, and done so in a safe way. So I think it's a really powerful technology, an amazing tool and set of tools really that we're starting to see come into the fore and that we're learning to use. But I think we really have to do it safely and make sure that these things that we were just talking about, equity doesn't get impacted by a model that you don't know exactly what or how it's doing when it decides to say somebody's eligible or not eligible. So I think we're first testing sensitivity, specificity, accuracy, positive and negative predictive value, getting basic understanding of how these are performing, and then ensuring that we're not losing aspects of equity, safety, security as we start to deploy these in our clinical trials.
And just to add in AI, and I'm sure you agree that AI doesn't have inherent biases. It's the system that may have inherent biases within the system. So it's really important that we recognize that and put guardrails now to recognize that and then put those guardrails to make sure that the databases that we're pulling upon are not representative past, but more future-looking, forward-looking, and making sure that we are inclusive and that we're including everyone and making sure those guardrails are in place to make sure that we do that.
Great. So Dr. Martin, so on the AI, the large language model topic, I think you started using ChatGPT and creating some educational content. And I think even Dr. Asakadze has a poster here about this at the AHA. And I was wondering if you can comment a little bit about that.
Yeah, we've had some fun playing around with ChatGPT large language models for developing patient education. Monday, is it the morning? Yeah, Monday morning, check out Dr. Isakadze's poster where the patient educational content is being created through a hybrid approach of human-centered design feedback from patients, clinicians, plus content analysis and generation from ChatGPT. It comes up with interesting ideas. It can explain important concepts in ways that could maybe be more engaging for our patients than we naturally would come up with. Not that you take the output and immediately say, here's our patient educational content, but take its ideas, integrate it with the clinician review, and ultimately that's what we've done to build scripts for animated videos that really our patients are engaging with, and as I said earlier, kind of binge watch, and then they crave the content and they want more. So we're finding it interesting in that realm in using it for patient education.
Great. So, Dr. Golbus, I heard that your research is surrounding something called just-in-time adaptive interventions. So maybe you could walk us through a little bit what that means and perhaps explain that and what other new types of study designs are you incorporating in your research that's using mobile technology?
Yeah, thanks so much. I love this question. So the idea behind just-in-time adaptive interventions is they're really trying to overcome the limitations of static intervention. So you can imagine that when somebody is using the same mobile application all the time, that you're going to develop habituation over time, and it's potentially not going to be effective or even not used at all. And so the idea behind just-in-time interventions is it draws on passively or actively collected data from a wearable device to deliver in-the-moment support. So to give you a very concrete example, we did a clinical trial that evaluated a JEDI, a just-in-time intervention, for patients who were enrolled in cardiac rehab. And the idea was we delivered notifications that were intended to augment and then extend the benefits of cardiac rehabilitation once they graduated. So these were notifications that accounted for things like the weather, the time of day, the day of the week, how recently they'd participated in cardiac rehab, and then delivered them a notification that encouraged either low-level physical activity or exercise planning. So again, these were meant to be notifications that were actionable in real time. And you can actually study how effective notifications are using a technique or a trial design called micro-randomized trials. And so the idea is that people get randomized to receive or not receive a notification at different times of the day, and you can see how effective that notification is. And the way that it works is you actually passively measure the response to the notification using the wearable. So for the physical activity example, you could compare the step count 60 minutes after they get a walking notification to the 60 minutes at the same time somebody didn't get a notification, and you can really determine the effectiveness of your intervention.
Great. I want to circle back to Dr. Blood, your research. So you had a very impressive, I think it was published in JAMA Cardiology, about your intervention with hypertension and lipid management, and you had tremendous results. It was really quite impressive, the number of patients that can get to goal with their blood pressure and lipids. But that was part of a research. So I was wondering if you could comment about challenges within scaling this and sustaining this, these kind of interventions in patient populations outside of research. So maybe what happened to your research program when with this after the study was over?
It's a great question. So as all good studies, we have to then build a business case and a business model for how you're going to push this forward. So we were really fortunate at Mass General Brigham to be internally funded for a number of years to demonstrate this technology, this process, this team-based approach was effective, safe, and led to impressive clinical outcomes. So thanks for your kind words. What we've now been challenged with after accomplishing that is how do we move this forward? How do we continue to deliver these services, help patients, help our providers, and continue to build a system and sustain it that delivers these clinical outcomes? There are a couple different ways we've been able to do that. The remote physiologic monitoring, RPM, chronic care management, CCM, these are billing codes. They're truthfully not a large enough dollar amount to really sustain a program and a team of the size and scope that we've been doing. So what we've actually started to aim at really is more in a contracting with payers as well as health systems, pay for performance type of metrics. So, there's a large, even in hypertension, there's, a lot of health systems that have contracts that up into the 7 figures and beyond that are meant to help and incentivize systems to control measures of chronic disease in their patients. So what we've been doing is starting to partner with providers, population health management groups, and starting to build this out as a way to reduce some of the financial penalties as well as downside or upside that we can have with our contracts so that we can become a part of this value delivered to the patients. And again, we know that hypertension, lipids, these are generally things that play out over years or decades. So the clinical events aren't going to accrue in that year, but the pay for performance we kind of see as a bridge so that we can say, hey, we're going to deliver the clinical outcomes, and we know these clinical outcomes are associated with reduced incidence of detrimental events in the years to come, but we can't be expected to be paid 10 or 15 years from now. They're not going to be on your health insurance. They might not even live in the same city or state. So what we've tried to encourage with our contract and our population health management financial teams is that it does make sense to, from a population health approach, to help these patients, to encourage them to utilize and build these systems and using these intermediate outcomes so that we can deliver the services, help them reach their targets, but also deliver a financial return for the system so we can sustain the services we deliver.
Great.
It's kind of the short-term versus long-term. I mean, short-term, you hope to at least break even for the system. Sometimes that doesn't happen, but it's more of the long-term. Are you reducing readmissions? Are you improving quality of life, core measures, those sort of things? And I think that's a big challenge is the monetization of all of this. We can work on the clinical side and get great outcomes, but it's just getting the payer mix to match that value add.
And truthfully, hypertension and lipids are extremely important. We know they're valuable. They're very much associated with the clinical events we see oftentimes as cardiologists. But heart failure is one where the business case is actually a little bit more clear. The outcomes are it's a much higher risk population. The outcomes are more short term. So that's a little bit of an easier patient population to make a business case on. And I know we actually have some talks at this in the days to come about those business models and how you can look to optimize and deliver on those. But I think as we start to shift to value, my colleague is exactly right. We have to start thinking about investing upfront and not only delivering the just-in-time stent or the just-in-time heart failure admission. You really want to go upstream and say, how do we mitigate some of those cost accruals? And it takes some investment. And I think we have to make sure that we're structuring payments and aligning incentives so that we can do that in a way that's sustainable.
Thank you. Well, I wanted to turn to another topic before our last few minutes, and that's something we all care about as clinicians and researchers, is patient privacy. So, now if we tap into these devices, I mean, there's so much information. We can do geocoding and, find from smartphones where they been, participants, are been and their location, and there's so much information. So how do we protect that privacy? And then, has this been a barrier in terms of working with IRBs? I know that's something they're concerned with. Dr. Martin and I are IRB at Hopkins. Sometimes it can be a little difficult, but rightfully so. They have the patient's best interests in heart. And so have you found barriers in getting your research approved because of concerns of privacy? And what can we do to protect patients and study participants when we use health technology for research? So I don't know if somebody wants to kick it off. This is a hard question.
It is a hard question. Jesse has a lot of experience with this.
Yeah, I mean, so I think from an IRB perspective, our IRB has actually been really supportive and has been a great partner with us. I think that I guess I have a couple of answers to that. I think first, I think from our perspective, patients are realizing that their data is out there, and so they really want a return on their investment. So if they're participating in their trials, they actually wanted more customization. So around these just-in-time adaptive interventions, right, we were kind of made the notifications maybe a little bit more generic. We were afraid that they didn't want that like really personal notification, and actually they do. They want it to be highly tailored, and that's work that we've done in some feedback sessions that we've gotten, some human-centered design sessions after our clinical trials. So I think that's one answer. I think the other is just really trying to help inform patients about where their data is going. So part of our standard processes as part of our group is that at the end of the clinical trial, we help them remove the study application from their phone, but we also offer to help them remove all of the other applications that maybe they downloaded that were not trial related. So there's the Fitbit application and the Omron blood pressure, application, and all of the different apps that maybe they had to download to be part of the trial. We make sure that they understand that their data is still going to these third-party entities, even though they're not participating in our clinical trial.
Yeah, I mean, I'll just briefly add, I agree with everything Jesse said. I think part of it is just being very transparent with patients, as you said, about sort of why we need data, how those data are being used, where they're going to be stored. On the technical side of things, it's, working with really good engineers that understand the importance of data privacy, and that starts to get into technical things like where, in the cloud, where is it stored, and is it in a Kubernetes cluster so that one set of patients' data is separate from another patient set of data when you're starting to do multiple studies. And so it starts to get very technical. So you want both, I think, really good patient communication as well as really good technical side of things, the way that data are handled. And I mean, if we get through all the hoops of our IRBs at our universities, I think that is a good test of how good a job we're doing with, because we certainly have to jump through a bunch of hoops.
And some employer-employee medtech innovative projects that I've worked on, the employers want to know the pulse of the health, mental health, physical health, well-being of their employees. The employees don't want the employers to know all of their business. So how do you put this in a population health type of platform to give to the employers to say, this is what's happening with your employees? And that is, I think, a big gorilla to figure out, and I think employers and employees want the data, but doing it in a very safe and protected way.
Great. We have less than 2 minutes left, so just something quick. I wanted to know if any of the panelists wanted to share with the audience anything cool coming down the pipeline. Is there any new innovations of health tech that have implications for our research?
So I'll just jump in real quickly. I think, if people are wearing wearable devices right now, we have FDA approved for EKG, for pulse oximeter. I think the two next big areas are cuffless blood pressure detection that are calibrated and proven out in elderly patients and younger patients, in Fitzpatrick scales like we talked about, and also with remote glucometer readings. I think these are, when we talk about vitals, blood pressure, heart rate, pulse ox, the pulse rate, rhythms, the big next barrier, I think, is blood pressure detection.
Okay, great. Any other quick comment, and then
I'll just give a shout out. I mentioned like our ERIC study and the PCORI trial. I just want to give a shout out to the AHA has funded a collaborative project of our strategically focused research network that really Jesse and Alex Sandu have been key drivers of. That's going to focus on a digital toolkit for heart failure patients to optimize GDMT. So keep a lookout for that in the coming year ahead.
Great. Well, I think we need to end at this note because we're out of time. I wanted to thank our panelists for this fantastic discussion. I really enjoyed all the comments, so let's give them a round of applause. And then please stay tuned. We're going to proceed to our next part, which is the Innovation Showcase. So please stay around to hear these great presentations.
Are we ready? Good? All right. Well, welcome everyone. My name is Nick Hendren. I'm a heart failure and transplant cardiologist. In addition to my day job, I'm also the medical director for heart failure at Parkland Hospital, which is Dallas County's safety net hospital and a very large purveyor of heart failure care. So as we all know, guideline-directed medical therapy for heart failure is suboptimal. This is data from the CHAMP-HF registry. We all know this well. Both doses and level of prescriptions are inadequate. And unless you do something, we know that these rates do not improve significantly over time. So one of the aims I had as I took over as medical director of heart failure a couple of years ago was really to understand what does our heart failure population look like in our safety net hospital, how are we doing with drug medical therapy, and what options do we have to leverage technology to build forward and innovate and improve on the care we're giving. This is data from our heart failure registry, which encaptures all patients with an ejection fraction under 40%. As you can see on the column on the left there, that encompasses just under 5,300 patients. It is a younger population compared to some of the other heart failure populations, predominantly a black, non-Hispanic, and white Hispanic population at 40 and 35% respectively. And as we are not a Medicaid expansion state in Texas, our patients are predominantly unfunded. About 65% have no funding in place, and about 12 and 6% respectively have Medicaid and Medicare. So despite some intentional efforts, we have looked at trying to improve our rates of guideline-directed medical therapy. You can see our numbers here on the left side of the screen. Those that are seen in our heart failure clinic, we're doing rather well. We've made intentional improvements over the last year. But those that are not seen in our heart failure clinic due to bandwidth issues, again, there's some opportunities to improve significantly on the rates of quadruple, triple, and even dual therapy for our patients. And so we need to create some innovative solutions and some ways to move forward beyond just the old pathway of seeing people in clinic. And as the others highlighted during their introduction talks here, there are some gaps traditionally in the digital health opportunities. At least for our population, there's difficulty in getting transportation to the clinics. There's a number of heart failure visits that are historically required to improve and implement GDMT. Our heart failure clinic is bandwidth limited, although we'll be improving that in the next couple of years. And for our patient population who's traditionally been disserved by traditional medical and healthcare facilities, there is some health system distrust that is a barrier to coming to these medical and incentivizing them. So what have we looked to do as a healthcare system? Well, we are fortunate that we are essentially a closed system as a safety net hospital system. And so we have leveraged our healthcare system contracts that is independent of payer status to create a level to allow for remote home monitoring devices. Those devices include capturing things like a digital scale, heart pressure, heart rate, blood pressure, and that feeds into a digital device that works on cell phone towers rather than just through the traditional cell phone networks, as many of our patients do not have Wi-Fi or access to cellular phone devices. We have worked to integrate these digital solutions seamlessly within Epic so that it is not a different website that you log into and pull into. It all populates and pulls within the EMR to reduce the work and the yield on our physicians. And we have worked to create a digital health team, again, within our safety net hospital, a team of nursing, pharmacists, and physicians, among many others, who can help act upon this data and information, because without acting on it, nothing is going to change.
And we really believe that this digital health is going to allow for a greater degree of confidence in GDMT adjustments. It's going to improve the rate and the rapidity in which GDMT is increased, and ultimately at a population level, both improve the rates of GDMT, but more importantly, the health care outcomes, including reductions in heart failure hospitalizations. Now, we're going to be partnering with the AHA to work in a prospective randomized setting to work together in a programmatic way to use digital health and some of these digital remote health monitoring to actually look at whether this manifests and changes in a low socioeconomic population. And we're expecting those results hopefully to be published next year for 2024. But just a quick snapshot of what we've done as we've started to roll this out and dry run this, and so we know we're ready to go in implementing this. This is data from our unfunded inotrope program, so patients that have no funding that our institution pays for inotropes. For these patients, we have selectively used digital home remote monitoring, and you can see here that in over nearly 1,500 days of support outside on this program, receiving inotropes with those digital health solutions, we've been able to keep them out of the hospital about 90% of days. There's been several kind of expected PICC line adverse related outcomes, but overall this program has saved net north of $3.5 million. And so as we look forward to rolling out our solutions to GDMT in a high-risk socioeconomic population, we really look forward to these partnerships that we expect to be successful and fruitful going forward. Thank you all.
Hello? Great. So, this is health innovation. So the way the AHA has done that is they've gone and thrown me in because I actually am not a cardiologist and I don't study the heart. Turns out I study the brain. But in spite of that, I'm hoping that what you're going to take away from this talk is how important even my work that's looking at it different from a therapeutic target, different focus, that digital is actually the new future. And this is where we're all headed for. And it really sort of builds on what's already been said. So we've been thinking about sort of in this space of inclusiveness, how do you get to this digital reality? So here's where we kind of are today. And we're now starting to layer onto that some digital aspects here. This where we really need to push, because right now a lot of this is high cost, high burden. So what we really need to push is bringing in new technologies that are going to lower the burden on the healthcare system and also lower burden overall in the participant. And where we really need to go, which has been mentioned, is sort of this idea of getting to passive engagement technology that's been touched on, and that's going to further drive down costs and also lower burden. So at Boston University, where I'm at, I'm part of the SFRN, Health and Technology Group, and we've been also focused on this participant-driven study that really, I think Seth Martin and the Johns Hopkins groups has really made that point, that you really need to bring it to the level of the participant as you're trying to figure out what to do. We do largely around the smartphone because it's the most penetrating technology in the world, and then we layer onto that some wearables and in-home sensors. And just to give you an idea of how we do this across a number of different metrics, we don't use one technology and one solution. We actually scatter so that there is overlapping, because this way our participants can choose which one works for them, and yet we're still able to get to the metrics of interest. And so this really gives you sort of an idea of how we scattered our technologies, knowing that our participants aren't going to choose all of them, they're going to choose a subset, but we're going to get to our measures of interest anyways. And so we've learned some lessons, which is one, that if you want people to do this, you want to give them a choice. And it turns out that 80+% of these technologies get used just in sort of different combinations. The other thing is that we have to be then very flexible, because we can't be really prescriptive in terms of our protocol in order to meet our participants where they are. And then, of course, we're constantly figuring out what are the technology changes and needs that we need to be addressing. So now what I want you to do is start doing a mind-stretching exercise. We often think about innovation as being something where we look outside of the box. And my question always is, what happens if it's actually not even a box? Because what we tend to do is even put parameters when we try to think creatively. And I think to take advantage of what technology is going to bring us, we have to think even beyond what we think we know. So I'm going to start with the concept of blood, because blood really changed everything. You know, this idea that we now, pretty ubiquitously, we can collect blood, we can measure what we know from blood, and we can store blood. And then, because we've stored blood, there are many things that have now emerged more recently, like in the genomics field, and then also we're storing it for future. Well, it turns out the digital is very similar. You can collect digital, you can analyze it using lots of now data science AI methods in the way that we understand, but you can also store it, and you can store it for what's going to come down the pike. So I think that digital is actually the new blood, and it's not disease specific. It's going to be able to be used for many different kinds of markers across many different diseases, not just the ones that I'm studying and not just the ones that you're studying. I'm going to give you an example. I work with the Framingham Heart Study. I started to collect digital voice recordings in 2005, when no one had an interest in digital voice, I might add. And we've been collecting them systematically. We actually have over 10,000 now. And I just want to point out to you the science. My first publication was actually in 2017, and it wasn't even in a clinical journal. It was in computer science engineering. Turns out that the vast majority of my publications in this arena have been in the last few years. So this is the idea. I collected that digital data, I collected it many, many years ago, and then science started to catch up, and I've been able to turn it into science. So that's the concept I really want you to understand here. So where are we headed? I think we're headed into a new arena of digital biomarkers. We're going to combine it with advanced analytics, and we're going to start to find these different kinds of biomarker patterns. They're not going to be static. They're not going to be the concept that we think of as biomarkers now, but nonetheless, they're going to come together at high specificity and accuracy. And this is going to then lead us down a new path into both clinical trials and clinical care. So with that, I am actually going to end on time. Thank you.
Good afternoon. My name is Mayor Krieger, and I'm going to be talking about oximetry, a racially biased measurement. Now, all of you have had your blood oxygen measured. How does it work? Well, there are two sources of light, infrared and red, that basically generate a light signal, and on the other side of the digit is a photodetector, and at the other end is an oximeter, and that's how it works. How did we get here? Well, there have been innovation milestones. So in 1860, first innovation was the invention of the spectrometer. In 1934, oxygen saturation was measured by the transmission of red light through an unopened artery. In 1934, same year, a device was designed that used two wavelengths to measure the same thing. A second wavelength, green, was actually added. And then, during the Second World War, oximetry actually was used in pilots to make sure that they weren't dying when they were up at very high altitude. In 1964, Shaw designed an 8-wavelength ear oximeter, and what we currently call the pulse oximeter was invented only in 1972 in Japan, and 2 wavelengths were actually used. The device apparently did not need to be calibrated. Hewlett-Packard developed an oximeter using 8 wavelengths in 1974, and I actually used that oximeter in thousands of studies starting 1974. So oximeters from that time migrated from research labs to routine clinical practice, and all over the place, in the ICU, in every single clinic, every time you've had your oxygen saturation measured, a pulse oximeter was likely used. Oximeters became over-the-counter consumer items. There are literally hundreds and hundreds of them that are in the market. You can get them on Amazon, Walgreens, you name it. None of them is FDA approved. Then the pandemic hit. So when the pandemic hit, as you recall, many patients developed respiratory failure, and when they came into the emergency room, short of breath, somebody would measure their oxygen saturation and then tell them to go get an oximeter. If your value goes below a certain level, come on in and we'll take care of you. And this was an example from the national health system in the United Kingdom. Well, there was a problem, and the problem was this wake-up call that came in December 2020, and this was actually a letter to the New England Journal, racial bias in pulse oximetry measurement. And what this study showed is that 17% of black patients had occult hypoxemia. In other words, they were hypoxic, but the hypoxemia was missed by pulse oximetry compared to 6.2% in white patients. Well, for those of us who've been using oximeters for a gazillion years, this was actually really old news. In 1948, it was reported in the proceedings, the Federation proceedings, that in fact, oximetry was much less accurate in black patients than in Caucasian patients. So this was very, very old. So there's nothing new under the sun. Hewlett-Packard, when it produced its oximeter in 1974, was aware of the issue, and their oximeter was studied extensively in both black and white patients. They supplied validation data in the manual that came with it. You could actually see how good the device was, and you can calibrate the damn thing. So there were papers in 2005, 2007 that cautioned that oximeters may be inaccurate, yet to become FDA cleared, the FDA requires data from 12 people, only 2 of whom need to be of dark skin. Totally crazy. So here are my suggestions for the FDA. Bump up total number of data requirement. You need to study this in all skin tones, as was mentioned by one of the speakers. You need an objective measure of skin pigmentation, and they should ban uncleared or unapproved skin-facing devices of medically significant metrics such as the EKG, glucose saturation, and so forth. So, and they need to publish validation and technical data, which they currently are not required to do. So I'm just going to let you know that the Office of the Attorney General, this is literally from last week, that they are telling the FDA that they need to deal with this issue. Thank you.
Hi, everyone. I think we're loading slides. It is fantastic to be with you today. So this morning, you heard from Dr. Martin and Dr. Marvel about Johns Hopkins Center for Health Equity and our work with a virtual cardiac rehabilitation. And today, I'm going to focus on atrial fibrillation and take you on the journey of building and testing the virtual digital health platform for AFib management. All right. I think my clicker is not working. Okay, so great, we're back live. So I want you to take you on the journey of patient Robin, who was diagnosed with the atrial fibrillation. Let's hear her experience with AFib. Audio. Okay, so what she's saying that when she was diagnosed with atrial fibrillation,
and then when the AFib hit, sometimes I was struggling to get up the steps. It was inconvenient and terrifying at the same time.
all right, so atrial fibrillation is unbelievably common arrhythmia. Okay, 1 in 5 individuals over time will develop atrial fibrillation. And it is associated with increased risk of stroke, death, heart attack, poor quality of life, and really poor mental health. The core pillars of AFib management include, rhythm control, rate control, so risk factor modification, and stroke prevention. And one of the kind of more overlooked risk factor and core pillar of AFib management is managing risk factors. And as you can see on the slide, there is a lot of components of the risk factor modification, and it's very complex. And it's a class 1 guideline recommendation to modify risk factors, but yet we have no structured ways of addressing risk factor modification. So this is Dr. Martin and I on cardiology service in 2018, and we had lots of patients on service with atrial fibrillation. We were thinking about the ways how we can leverage, what tools we can leverage to really deliver risk factor modification to those patients. So we resorted to human-centered design. There was a lot of talk about human-centered design today when we are starting ground up. So we engaged patients, diverse groups, and their caregivers in the human-centered design, where we really involved them in the understanding of what the challenges of lived experiences with AFib was, and as well as together with them, we co-designed the intervention to better manage AFib. And we even published the approach to human-centered design with virtually that potentially can be applied to other chronic disease management. Our work was then even cited in the White House document, and of course we were supported with the American Heart Association to do this work. The intervention is a comprehensive AFib management leveraging the Cori AFib app, also a clinician dashboard where we get the actionable data from the smart devices and also app data. And we had an Apple Watch. We also had a home sleep study that patients were screened for sleep apnea, scale, and blood pressure cuff. Education, as Dr. Martin mentioned, we were created with a patient input. And also, we have a clinician dashboard where the nurses check in with the patients on weekly basis to review their progress with the risk factor modification. We have a continued iterative process where the feedback from the patients is taken into account to further improve the intervention. We collaborate closely with Apple, and this is goes to the scalability that was discussed earlier today, that we want to engage the industry leaders to be able to scale the intervention. This brings us to the pilot randomized clinical trial, our work with the human-centered design and really building the intervention. Now we are running a 100-patient pilot randomized clinical control trial at Johns Hopkins, and we have health equity focus. We are doing technology onboarding for patients, and we are really focused on enrolling patients from diverse backgrounds. This is a 12-week intervention, randomizing patients into the comprehensive care AFib program versus usual care alone. We are almost halfway enrolled, and we are looking forward to scaling this up in the next clinical trial. So let's hear Robin's experience with the intervention.
Ability that I didn't have before that I now have. And with the nurse, things that I have been putting off. I now have someone going, hey, what about this? In the short time I've been in the program, I've done my sleep study. I've got my CPAP machine, and I'm doing well with that. She also connected me with a nutritionist who's helping me address my eating habits. Absolutely. I wish they would have had something like this because my dad has the same condition. He and my aunt, I feel like things could have been very different if they would have had access to the things that I have now, because just not having to wait 3 months, 6 months, 9 months until the next time you see your cardiologist, with the nurse checking in with me and everything being looked at daily and weekly, it can make all the difference.
All right, so our vision is now to scale the progress and success that we had with Robin and deliver the intervention to all patients across the world with AFib. So thank you.
Good afternoon. I'm Doug Romer. I'm not a cardiologist. I'm a family physician from Dayton, Ohio, here on behalf of Igor Granoff. What we're talking about today is the challenge of hypertension, the silent killer. We're just obviously trying to say this is a very common problem throughout the world and the United States. Obviously, the consequences are horrendous. However, the current treatment guidelines focus on vasoconstriction as the predominant cause of hypertension, and we're here to discuss that today. So the methods was, NICAS is a non-invasive cardiac system. It uses impedance cardiography, hemodynamic and fluid measurement system. It also provides highly accurate hemodynamic patient profiles. It's very easy to do, 2 sensors, easy to use, and very cost effective. The interesting thing about hypertension and hemodynamics is right now in blue, you can see we measure blood pressure, we may have a decent heart rate. But what NICAS provides is total peripheral resistance, cardiac output, total body water, and stroke volume. So now we have the complete picture of what's causing hypertension. In addition, the other methods are that we also use MedsEngine, which is an EHR integrated clinical support application for chronic disease management. As you can see, a patient is sitting in with their physician in front of their EHR, any EHR. They simply click a button in the EHR, and then the patient information is retrieved from the EHR, it's then uploaded into the cloud, and then guideline-driven recommendations are then generated. Quickly, the patient-specific recommendations are displayed back to the patient and the physician to discuss. What they'll end up seeing is this report for hypertension. So the upper left is simply blood pressure measurements. Red simply catches their eyes. It's not normal. We like to get it back to a green area. In the upper right corner is the hemodynamic result of the testing that's up there. As you can see, there's a little black triangle to the far right that suggests that this patient is hyperdynamic. Down below, what we show is what all those components are. So for your arteries, we measure total peripheral resistance. We do have this in colloquial terms for the patient, so when they take this report home, they can understand better what's going on with them. In addition, under your heart, we have cardiac power index. Obviously, this is a red bar. Something is not good there. Below there are the 2 components. So we have stroke index, completely normal, very green, and then we have high cardiac rate, which is up. And then total fluid content is also measured, usually not going to be much of an issue. In that lower left box is your facts. So we do take things into consideration like age, race, CKD, other things that may affect our drug choice. When that's all completed, we then come up with 5 drug recommendations, 1 through 5. The first drug, as you can see here, is going to be our highest rated drug that's going to match the hemodynamics of that particular patient. So in this case, we're actually using a beta blocker because of its effect on cardiac power index and heart rate. The patient takes this home, gets to review this, and has a very good understanding of what's going on. The method, as far as process goes, this is pretty typical. You check the blood pressure in the office. If the blood pressure is higher than 140/90 the second time, the NICAS is done. It's then uploaded into the EHR like we mentioned. This is then validated. The patient and physician review this, and then we go on to prescribe the medications, and we see this patient back in a month until this blood pressure gets a goal. So what happens with this? In our study, we had 14,698 patients in a community-based cohort. You can see the demographics below. Of significance, there was also 22,346 ICGs being performed. What we showed, and the best way to look at this is actually to look at the graph on the right. So what we measure is that mean arterial pressure, cardiac index, cardiac power index, and total peripheral resistance index. What that generates is a graph that says where the patient's hemodynamics are. On the left, you'll see individual blue dots. That represents these patients. 47% of these patients have pure vasoconstriction. But on the right, in the pink, these are patients who have no vasoconstriction at all. They are simply with high cardiac power index at that point in time. And then in the middle, in yellow, those are the patients who have a combination of both. Interestingly, no demographic feature really predicted the physiologic grouping. What I simply mean by that is, for example, age greater than 60, we now have pure vasoconstriction at 50% in those patients. Over to the right, they're hyperdynamic 20% of the time, and they're mixed 30% of the time. If you look at a younger population, age 18 to 59, only 41% of these patients have pure vasoconstriction. 32% have no vasoconstriction. They're all hyperdynamic. The middle section is the combination of the two of those. So what we ended up doing is making the recommendation based on the hemodynamics. So typically, those patients with vasoconstriction were given drugs in blue. We're all used to these ACEs, ARBs, CCBDs, and thiazide diuretics. The patients on the right with no vasoconstriction, pure hyperdynamic, they were given beta blockers, CCBNDs, based on the cardiac power index, heart rate, or stroke index being affected by these drugs. Down below in the yellow are the folks who had a mixed hemodynamic stage, and then we used beta blockers with vasodilating properties to affect those patients, and then CCBNDs, which would also begin to affect both vasoconstriction, cardiac power index, et cetera. Occasionally would use diuretics, but not often with hypertension. So the results of this, our goal at this point in time when we started this study was a blood pressure less than 140/90. So hypertension control rates, this is what the CDC had back in 2016-18, 44%. Primary physicians had a 92% average blood pressure control rate for 9 years. Every single one of those years, they were above 90% to goal. A second group joined us, Premier in Pittsburgh. These physicians got to 85% to goal. So this is substantially improved from what we've been using throughout the U.S. and the world. Interestingly, the Pri-Med patients, we were actually to get their blood pressure to goal in 1.4 visits to 91.5%. If you did continued ICGs monitoring these patients, you can improve their blood pressure control. So when we looked at MI and stroke incidence, patients with hypertension obviously have an increased risk of MI and stroke. So what we did is we compared the patients without hypertension, average age of 43, against patients in the population with hypertension, had hyperdynamic management, average age of 61. What we found was, with the 8-year average incidence, these were pretty similar. So similar incidence of stroke and MI in both groups when you control patients to goal at 92%. So our conclusions are to treat hypertension to goal, determine the hemodynamic cause of each patient's blood pressure, display the data to increase physician and patient understanding of the precise cause, and treat according to that elevated blood pressure. RX a drug class that matches the hemodynamics, and then follow up that blood pressure until it's at goal. Results, as I mentioned, 90% to goal for 10 years, and then preliminary data suggests that patients with hypertension whose blood pressure is managed based on hemodynamics using NICAS and MEDS engine have a similar incidence of MI and stroke as compared to patients with hypertension. We recognize in future directions, RTCs are needed to confirm the data, and if confirmed, could significantly improve the treatment of hypertension in the poor sequelae of untreated hypertension. Thank you very much.
Can you all hear me okay? All right. No slides for me. I'm just going to have a conversation with you all. My name is Joe O'Rourke. I'm from Walgreens. I'll give you a little bit of background on myself, and I'll talk a little bit about Walgreens and what we're doing and why I'm here today. I've worked in clinical trials.
Attention, please. Thank you for visiting the AHA Science and Technology.
She'll get your attention first.
We hope what you learned today will have a meaningful impact on your practice or research. The exhibit hall is now closed, but we want to remind you to return tomorrow to visit more exhibits and take advantage of the in-hall education. The exhibit hall will reopen at 9 a.m. tomorrow. We also want to remind you to wear red tomorrow to Go Red for Women and show your support for ending heart disease and stroke in women. Again, please join us tomorrow in the Science and Technology Hall from 9 a.m. to 5 p.m.
Let's try that again. I've worked in clinical trials, clinical research for about 20 years. I started at Hopkins doing metabolic research. I moved into clinical development-focused companies across everything from measurement science, patient safety, investigator training. I worked at a company that was one of the largest central IRBs. And I came to Walgreens because of the increased focus on the need to enroll trials faster and in a more representative fashion. And we have seen the increased attention at a federal level, FDA level, news media level, up here, the focus and energy on how do we bring research opportunities to underrepresented and under-accessed populations. Now, I came to Walgreens to help grow our business unit that was launched about 1.5 years ago. And in the process, I've had the pleasure of talking with physicians, researchers from all over the country, whether they're cardiologists, whether they're oncologists, and ask them about the patient populations that participate in their trials and what they need help with. If you're trying to send me a message, I'm just going to keep going. And what's been fascinating is people say, I need help. I need help recruiting Black, Hispanic, Asian American, Native American, many other underrepresented populations. And I said, well, do you want us to set up a satellite location, a satellite Walgreens location, co-branded with your hospital healthcare system, over here, 25 miles away, in that community that's not participating? And he said, that sounds okay. How about right outside of my hospital? Because I can look out my window and say people on the street who don't think my hospital healthcare system is for them because they're not insured, they're underinsured, there's a socioeconomic consideration there, there's cultural considerations there. And so what I've found is there are phenomenal efforts underway bringing people into clinical trials who have never before been adequately represented, whether that's as basic as having the right balance of sex that you're supposed to be representing in the underlying population, or more sophisticated to make sure that you have a representative of the broader population that you're seeking to study. So what's Walgreens been doing? So Walgreens' thesis was we have 130 million people who trust us with their prescriptions and have a long-term relationship with us in that way, with our pharmacists. We know a variety of things about them. We know their medication history. Sometimes we know more of their health history, et cetera. And we're a covered entity. Can we reach out to those people and invite them into trials on behalf of all of you who are doing the research? We're not suddenly becoming clinical experts in the and doing a lot of clinical research ourselves. I'll touch upon that a little bit more. But what we are doing is we're bringing trials to patients in different ways. That can be as simple as texting and emailing them about a local study opportunity to them in a given community. That can be as sophisticated as standing up a clinical trial location at a Walgreens where there's appropriate physical space under the oversight of an appropriate principal investigator with local staff that can be a clinical research coordinator, nurse practitioner, et cetera, appropriate for any sort of simple clinical trial opportunities. We're not doing MRIs in Walgreens locations, but we are doing blood draws, EKGs, things like that, to help facilitate and lower the burden for participation in research, to help bring trial opportunities to patients that are not traditionally accessed. So let me just check the time here, so it's a little bit off with the announcements. Let me talk a little bit about our results. So we launched about 1.5 years ago. We've run trials from everything in vaccines to Alzheimer's to atherosclerotic vascular disease. We just did a press release with the Cardiovascular Research Foundation where we're going to help power their study of valvular disease at a population health level. So we looked at our recruitment efforts across all different areas. So not one of those studies, just kind of in general. And we saw that 46% are self-reported minorities, which is phenomenal. It's 30% where it's clearly someone is saying, I report myself as Black, I report myself as Hispanic, I report myself as of Asian ancestry, and about 14 to 16% are saying other. So you can kind of look at 30% self-reporting that way, 14 to 16% self-reporting as other. It's what the FDA has demanded for new registrational trials of interventional treatments that are going to them for approval. But more so, it's what our society has demanded. So there's a lot more work to be done, but I just wanted to share a little bit about that today, and of course, welcome your questions after. Thank you, and if anyone wants to shut off the lights all the way now, I'll exit quickly.